My name is Chaitanya Vadlamudi, and I'll be presenting the HerQLes assessment of individual components, a 5-year AHSQC analysis. I have no disclosures to report. Ventral hernia repairs have been shown to improve overall quality of life by the validated 12-component hernia-related quality of life survey, also known as HerQLes, shown here. As you can see, each component of the questionnaire states how a patient's hernia may disrupt their quality of life and is rated on an ordinal scale from 1, strongly disagree, to 6, strongly agree. A summary score is then produced from 0 to 100. To date, however, no analysis has investigated which aspects of this questionnaire improve after ventral hernia repair and whether this varies with hernia size or surgical approach. This is of key importance when setting expectations with patients prior to a ventral hernia repair. We performed a retrospective analysis of ventral hernias over 5 years, from 2014 to 2018, using the AHSQC database. We specifically measured the change in each individual component of HerQLes at the 1-year postoperative follow-up. This was performed using a Wilcoxon signed rank test. The median change in individual components at 1-year follow-up between hernia sizes or between surgical approaches was also compared by using the Kruskal-Wallis test. We defined small hernias as less than 2 centimeters, medium as 2 to 6 centimeters, and large as greater than 6 centimeters. We compared pure open, laparoscopic, and robotic approaches. Combined or hybrid approaches were excluded. There are 1,875 ventral hernia repair patients in our cohort. The average age was 58 years old. Half of our cohort was female, and the population was predominantly Caucasian at 92%. The mean BMI was 32, and the majority of patients were ASA Class 2 or Class 3. There are 1,509 open, 140 laparoscopic, and 226 robotic cases. There were 289 patients in the small hernia group, 325 in the medium hernia group, and 1,261 patients in the large hernia group. The vast majority of these patients were functionally independent, non-diabetic, and not actively smoking. On average, they had undergone 1.9 hernia repairs prior to this intervention. 25% were grade 1, 60% were grade 2, and 14% were grade 3 hernias. When looking at the entire cohort of patients, we found the median improvement between baseline and 1 year for every component to be significantly improved with a p-value of less than 0.0001. Here the median is denoted by a white or black line, and the mean is denoted by an X. Within the small hernia subset, every component also significantly improved with a p-value of less than 0.0001. However, here we see far greater variance in the interquartile ranges. The highest median improvements and interquartile ranges were seen with physical pain, strenuous activity, and moderate activities. Conversely, the interquartile range of health impact includes a -1, meaning that the abdominal wall actually had more of an impact on their overall health 1 year after their operation. Similarly, with the medium hernia group, every component was seen to improve with a p-value of less than 0.0001. Again, the highest median improvements in interquartile ranges were seen with physical pain, strenuous activities, and moderate activities. The interquartile ranges for the remaining components were slightly higher than the small hernia group. In the large hernia group, we also see every component improve with a p-value of less than 0.0001. Here we see far less variance in the medians and interquartile ranges. We then elected to compare between hernia size groups and found 8 quality of life components that were significantly different between the 3 size groups, with a p-value of less than 0.01. The median improvement in scores and interquartile ranges was consistently larger for the large hernia group. Of the 4 components that did not show a difference between hernia sizes, 3 were physical pain, strenuous activity, and moderate activities, all of which had showed significant improvement even in the small hernia group. In fact, within the small hernia and medium hernia groups, these were the 3 that showed the largest effect sizes. The 4th component which did not show significant difference between groups was health impact, which consistently showed the lowest improvement across all 3 groups. We then compared the improvement in quality of life scores between surgical approaches. This was significantly different in 7 of 12 components with a p-value of less than 0.05. Laparoscopic approaches showed less improvement than open or robotic surgery with walking and stairs, dressing and cooking, sexual activity, required to stay at home, and appearing blue often. I accomplished less at work appeared to have a greater improvement with the open approach compared to laparoscopic or robotic approaches. Subgroup analysis by hernia size showed no statistical difference between surgical approaches and small or large hernias. For the medium hernia group, only one component, I accomplished less at work, saw a difference between approaches, the p-value equal to 0.02. In summary, All 12 components of the HerQLes Quality of Life Questionnaire improved after ventral hernia repair. This held true in all three size groups. However, the amount of improvement was greater in the medium and large hernias in 8 of 12 components. We suspect that these quality of life components were not impacted as severely in the small hernia group and therefore showed less change or improvement in postoperative scores. Within the small hernia group, physical pain, strenuous activity, and moderate activity showed the largest improvements. This is likely a reflection of the quality of life components that are most impacted in those with small hernias. Health impact showed the lowest improvement in all three groups, and a subset of patients in the small and medium hernia size groups actually had worse outcomes after surgery. Laparoscopic approaches showed less improvement than open or robotic surgery in 5 components. It is unclear as to the underlying cause of this difference. Tacks and transfascial sutures are often used in laparoscopic repairs and can result in increased pain compared to suture repairs. Interestingly, there was no difference in physical pain between the three groups. There is a higher rate of bridging repairs seen with laparoscopic IPOMs, but there is no literature to suggest that this could lead to long-term abdominal wall dysfunction. Open approaches showed more improvement with accomplishing less at work. Again, we could find no clear or obvious rationale for this in our study or in the literature. Finally, I would also note that even though the 7 components were found to be statistically significant between surgical approaches, there is some question as to whether these were clinically relevant differences, given that the means and medians for all 7 of these components differed by 1 or less. Some limitations that I quickly want to acknowledge are that this was a retrospective review, the groups were not randomized or matched, the hernia size criteria that we settled on was skewed towards smaller hernias. The 6 cm hernia, defined as large here, will often not require any additional advanced closure techniques such as component separations. We may have been better served by extending our size criteria for medium and large hernias so that the groups would have more clinical significance. There are also several confounding factors that I should mention. These include concomitant operations, hernia grades, postoperative complications, and prior hernia surgeries. Moving forward, we'd like to look at how each of these impacts the patient's ability to improve their quality of life after a ventral hernia repair. In conclusion, for patients, worsening quality of life is often the impetus for ventral hernia repair. Quality of life, however, encompasses a broad array of factors. This study suggests that patients can expect to see an improvement in all 12 components of the quality of life measured in the HerQLes questionnaire. The amount of improvement, however, varies with hernia size and approach. Further research to understand these differences will enable us to set appropriate expectations with our patients and choose an operative approach that better aligns with patient goals.